Welcome to this Partners in Care Mental Capacity webinar. This is webinar 14, Challenges in Assessing Mental Capacity. Partners in Care today welcomes Lorraine Currie, a mental capacity consultant, to talk about this very interesting and intriguing subject. If you are watching the webinar on YouTube, any associated resources will be linked below the video. Okay, Lorraine, over to you.
Thanks, Karen. Thanks, everybody. Okay, so I think this was raised by members, various different issues that might affect us when carrying out assessments of capacity, things that might cause some challenges. So it's kind of an edited collection today of various different issues. So here we go. So we're going to start really, as ever, before we look at the challenges of mental capacity assessments. We're going to just remind ourselves what we actually do mean. So it's always good to return to basics, and I don't think that time is ever lost. So when we're talking about mental capacity, really we're talking about the ability of a person to make a decision at the time it needs to be made. And what then do we mean when we're talking about a lack of capacity? Well, that means that if a person lacks capacity in relation to a matter, so a specific thing, issue or decision, at the material time, i.e. the time they need to make that decision, they're unable to make that decision in relation to that particular matter because of an impairment or disturbance in the functioning of the mind or brain. In other words, a person lacks capacity if they're unable to make a decision or take a specific action, and they're not able to do that because of a mental impairment. So we've got to have these various components present. We've got to have a mental impairment, and that's the reason for the inability to make the decision. So what do we mean then if we say that somebody's not able to make a decision? So again, we're going over the groundwork of how do we carry out essentially an assessment of capacity. And at its simplest, we're asking this first question: is the person able to make the decision for themselves? Then we're asking the second question: if not, have they got an impairment or disturbance in the functioning of the mind or brain? And if so, is that the reason they can't make the specific decision? So in essence, at its simplest, this is an assessment of capacity. And that might be a day-to-day decision. So we might ask these three questions and make a very simple note, or it might be a more complex decision, and we might ask these three questions and make a much longer, formal, written record of that. So first of all, how do we know if the person is able to make the decision? And that part of the test is largely what we will focus on today, some of the complexities around that. Because we work that functional test out by asking four questions. Can the person understand the relevant information in order to make a decision? Can they retain that information long enough to make a decision? Can they use and weigh that information in order to make a decision? And then can they communicate their decision? So this will be familiar to you. We've gone over it before, and we've produced certain bits of supporting material that will help you with these four questions. To make a decision, the person needs to do all four. Needs to understand, retain, use and weigh the relevant information, and then communicate their decision. So it sounds very easy, actually, to do an assessment of capacity if it's about just asking these questions and then considering whether the person has a mental impairment, and then asking the final question: is that mental impairment the reason they can't make a decision? Sounds really quite easy, but you've raised some complexities that you'd like to discuss. So I've tried to look at, well, if it is that easy, if it's a simple, straightforward test, mostly based on this functional test, then why is it often so hard to do? So we're going to look at some of the reasons why it might be hard, where we get ourselves tangled up in complexities. And sometimes that just happens because we don't identify what it is. What is the decision the person needs to make? Or what's the action that they need to take? And if we haven't identified that clearly, and I would add really simply, then if we don't know what that decision or issue is, how do we know what it is they need to understand in order to make that decision? And if we don't know what the relevant information is, how do we know whether the person's had it? How can we be sure as we proceed through an assessment of capacity that the person's had the information that they would need to make that decision? And this is the same that we all experience in our lives. You know, I've just made a decision about changing broadband. Might have been an unwise decision, actually, as it took place this morning. But in order to make that decision, I needed various bits of information, like what will it cost and how will the change take place? You know, I needed bits of information that came to me by email. And once I'd got that, I needed to be able to retain it and understand it. And we all use these same functional tests in decision making. So sometimes we struggle over thinking about, well, what's the decision and how do I know what they need to understand? But we've pointed previously in previous webinars to the fact that most of this work has already been done for us. So the documents that are referenced here are, in fact, they're referenced twice. I don't know why that is, but anyway, better twice than not at all. So the information on what you need to understand for decisions around care, for decisions around, let's say, using the internet, for sex, for medical treatment, this has all really been done, drawn out of case law and put in a nice, easy to use way in these guidance documents that we're referencing here. So don't reinvent the wheel. Some of this has already been done. And if you find yourself getting tangled up, then go and have a look and make sure that somebody hasn't already done this and you don't need to get tangled up in it. So I think the second thing in terms of sometimes finding decisions complex is about making sure that the person has the right support. So we know that the second guiding principle is that we need to make sure the person's had we've taken all practicable steps to support the person to make a decision. So we're not rushing to that capacity assessment without having given them the right support. But also, when we're carrying out a capacity assessment, the person needs the right support. And sometimes that means you might need to get resources from elsewhere. And this was a case that pointed out the pitfalls, really, in someone carrying out an assessment of capacity without a suitably equipped translator. And it nearly resulted in the person being seen to lack capacity because the right skills were not used in supporting them through that capacity assessment. So it's very important that if we're dealing with people whose first language isn't English, or if they have specific impairments where we may be able to support them. And the case went on to describe that any mental capacity assessment of a deaf individual who uses BSL, then you would need a BSL interpreter. And the assessor should have a background in understanding deafness and in engaging with the deaf community. And if you don't, then there should be an explanation about why you're carrying that out without that expertise. So although this is focused on deaf individuals, it really expands to any kind of situation where you're assessing capacity and a specific interpreter is likely to be of value. Also, support can be thinking about the way in which you carry out that capacity assessment. So it might be this is a person who is a particularly visual learner, or they value information being given to them in a visual format or a recorded format. Being aware of not using too many, what's the word? Kind of those expressions that are not easily understood by people who have very literal understanding. There's quite a lot there around how we support people through a capacity assessment. The other thing that's very important, and I've seen this time and time and time again, where actually the assessment is sort of almost set up to catch the person out because they're not given the information that they need in order to make a decision. And I don't think any of us would make a decision if someone said, well, I'm not giving you the information. You make your decision and then I'll give you the information. You know, we need that necessary information first. It's not a trick to test what they don't know. It's about sharing the information with them so that we can then see in a functional way whether they're able to retain it and use and weigh it. So in other words, we often see things written in capacity assessments that say, John, well, this would be a financial one, but it's the same in other types of subjects. John wasn't able to tell me how much his pension was or how much he paid in bills each month. So my first question, if I was reading that, would be, well, did he know? How do I know that he knew the information that he needed to know in order to tell you that? So it's about recording that we've shared that with him, but it's also about making sure we have. So a better conversation would say, sat down with John, we sat with his pension details and his bills, and we went through all of that information, looking at how much he got each month and how much he paid out. When I came back to talk to him a bit more about this, he wasn't able to tell me how much his pension was or how much he paid in bills each month. So in other words, we've made sure we've given the person the information that they need to make the decision. And the sort of other way of looking at it is, if you haven't told them, then you can't test it. No telling, no testing. I'm trying to think of little rhymes around this, but hopefully you get the message. You know, if we haven't told someone the information, we can't then carry out a test that looks at whether they've retained it and understood it. So it's not based on some sort of mystery that you know the information, but they don't. And we're sort of keeping it from them, but at the same time trying to test whether they've retained it, understood it, and can use and weigh it. Okay, so one of the things that you asked to focus on a little bit was whether we could look at executive dysfunction. And this is where this sort of comes in. When we're looking at, it's not so much that the person doesn't understand the information, we've given it to them and they seem to fully understand it, but there's some sort of issue with using and weighing that they're not matched somehow. So let's have a little look at this. So sometimes people understand, they do know the information. So we might have a conversation with them and they seem to have understood everything. Yes, they can tell us back, they've understood it. And then the time comes to apply that knowledge and they're not able to apply it. So they're not able to do the thing they've told us that they will do, and they're not able to use the information in order to do it. Sometimes we might see that in an assessment where the answers that the person's giving us, really perfectly good answers, we can't fault it. And this is going, as it's going along, we're thinking, this person's definitely going to have capacity. There's also issues around, is it just an unwise decision? Or is it one that the person does not have capacity to make? And there's like a huge chasm between those two statements, really. And when we're mulling over these things, they seem perfectly great in this interview, but the care staff tell me They don't do this, they don't do that, they don't do the other. Something's just not quite gelling here. I'm not sure if this is just unwise or actually if they lack capacity. These are the sorts of things that often lead us into considering the area of executive function or executive dysfunction. So there are some sort of beware statements here and equally some sort of be aware. So something's happened in the last perhaps year to 2 years, maybe longer, where executive function is the kind of thing that everybody is focused on. It's become this kind of big issue. I don't know how or why that happened, but it started to gain traction in a way, like a snowball down a hill. And everywhere you look, you're hearing about. Everywhere you look, you're hearing. Everywhere you look, you're seeing. And everywhere people are talking, there are issues around executive dysfunction. And the danger of that is that it's almost in danger of creating a different standalone test of capacity, which isn't correct. We've seen, or I've seen it written, executive capacity, as if you're testing and assessing something else, and that isn't correct. These impairments are being seen as something sort of unique and separate and unusual. So that's my warning. Beware of that. Do not let that lead you into thinking that there is another test of executive dysfunction or of executive capacity. But on the other side of that, you do need to be aware of executive dysfunction. You need to understand when the person might have issues with what we call executive function. And I think we're going to look at it in a minute. Hopefully, I've put that slide in. What do we actually mean? What am I talking about? You do need to know if there are issues with the higher executive functions and how that might affect someone in an interview situation versus a real life situation. And then bring that knowledge into your assessment. So there's a warning, but there's also a warning not to ignore executive dysfunction and completely throw it out, but it's not something separate and unique. So what do we mean by executive function? We mean those functions that we all carry out daily without even knowing. The things that have involved me in finally getting to the point of changing broadband. I've thought it through. I've done some planning, not very good planning actually, or I wouldn't have made that change today. I've carried out and worked out what are the actions I need to do. I need to stop thinking about it, and finally I need to ring Sky and say, I'd like to change. Other broadband providers are available. This is not an advert for Sky. I need to ring them. I need to get organised enough that I'm going to make the necessary calls and end one and begin the other, and so on. I'm using this example, hopefully, to help this thing make sense. So executive function is those higher functions that we all do. We all do this every minute of every day. You've all done it in sitting down at your screen. You've had to be organised enough to find the email that Karen sent you with the link. You've had to plan your day so that you had an hour and a half to give to the session. You've had to be mentally flexible enough to turn your camera off and mute yourself and all of those things. So these are nothing sort of unusual. They're things that we all do all of the time. But these functions can be impaired due to a number of things. We tend to think particularly of those that affect the frontal lobe, such as brain injury, frontal lobe dementia, and stroke. So those impairments can affect a person's ability to think, plan, sequence, carry out their decisions. So it's important because where those functions are impaired, we may find a person who can't translate their intention into action. They might be really plausible, full of promises, we might describe that. Not so much promises, but but giving a good account, but they can't initiate that. They can't plan and sequence the things they need to do. So they might, on a very low level, tell you in an interview that they can carry out all of the functions around getting washed, dressed, and so on. But yet they actually can't sequence those things. So they might be putting on clothes without taking off the pajamas, or they might not actually be able to get going with cleaning the teeth because the toothpaste isn't on the toothbrush. That it also can, executive dysfunction can result in impulsivity. So some things where they act before thinking about what it is they actually said they would do in those circumstances. Equally, they may have very rigid thinking or not be able to think abstractly. And they may have that lack of a filter in social situations and be difficult to motivate. So in an interview, abstractly, they may be able to tell you, yes, I've got no problem with that. I can do all those things myself. But actually, they don't get dressed. They don't have a shower. They don't do the things that they've just told you that they can do. So what does that have to do with an interview situation? So some of it's about actually how we conduct that interview. Have you got the person's full attention? Avoid speaking in an abstract way or using metaphors. You know, we do that often without thinking about it. We say all kinds of strange. I've got another session which is about language and some of the strange things that we say. And we have local variations on that. I think when I moved to Shropshire, people talk about, I think I've got this right, all round the reeking. And they mean that somebody took a long time to tell the story. We have a strange one in Oldham where we say, oh, she's not behind the door. You know, I don't really know what that means or where it came from, but I do understand it in a sentence. So not good things if a person has a very abstract way of does not understand an abstract way of speaking. Making sure that you are giving very concrete options that the person can identify with. But the most important really are these last two. Triangulating information when you've been given very plausible answers in an interview, and also checking with others who know the person well, which actually is part of triangulation. They say this, is that what they do? We'll say a little bit more about triangulation in a minute. So when we're assessing capacity, we've got to get this balance right. We've got to remember that the functional test looks at understanding, but it also looks at using and weighing. And we sometimes leave out the use part. So this is the ability of the person to put to use that information that they've understood and retained, but are they able to use it when that situation arises? So also do consider whether the person simply needs support to do those things, or are they actually prevented from doing so because of executive dysfunction? So what do we mean by triangulation? And this is about checking it out, really. It's a fancy word for checking it out. So you may have an interview with a person, you're talking to them because there's an issue around capacity, and they're giving a very good account. We've got some great answers. They say, you say, what would happen? Tell me what would happen if this situation arises. Tell me how you do that. Talk me through this, talk me through that. But then you go to somebody else and you say, this is what the person's told me they do. Is that your experience? Maybe you need to look at care notes. Maybe you need to actually observe them in the real world. I've seen this done very well with somebody who was very impulsive around crossing the road. Give the right answers when they're sitting and talking to you. And, oh, yes, I press the button and I wait for the green and, you know, so on. But when they're out, their impulsivity takes over and they just shoot across the road. And the social worker in this case that I'm thinking of went out and followed them. Sounds a bit sinister, but you know, they kind of observed them going out with a support worker, and the support worker having to sort of gently restrain the person's arm so they didn't run into the road. So it's about checking out. Yes, the person's account is very important, but checking this out with others. Sometimes this is kind of where the balance on empowerment and protection can go a little bit wrong. If we over focus on, we all only want to empower people, then in our desire to be strength-based, we can sometimes ignore the fact that they do have some dysfunction in carrying out these higher executive abilities. And if we do that, we miss the whole person. If we rely only on their account and don't triangulate, we might get a very wrong picture. And if we don't know how their executive impairment impacts them, then we can place the person at risk. Okay. So that's the sort of danger of over-focusing on empowerment only without balancing in the need to also sometimes protect. And that little section there was about looking at how executive dysfunction impacts people. So I want to now look at some of the challenges that arise around the presumption of capacity. And maybe you think, oh, I didn't know it did. Well, it does. So we're going back to basics again. The first principle in the list of principles, 5 guiding principles underpinning the MCA. And the first principle is that the person must be assumed to have capacity unless it's established that he lacks capacity. Take it as read, it applies to women as well, but legally seems to only ever refer to men. So this very strong presumption of capacity that is in the Mental Capacity Act. But I just want to show you some ways in which that is sort of misused, really. Because you'll see that we have to assume capacity unless we've established that the person lacks capacity. So what does that word, that little word, unless, what does it mean? Does it suggest then that unless means that we always have to carry out an assessment because there's this unless question? Yes, you do have an assumption of capacity unless there's an assessment that rebuts that. And it has to be strong enough to rebut that presumption. Or does it suggest, no, you can never mess with this principle because the assumption stands? So there's a question about when we act on that little word that says you assume capacity unless there's an assessment in a way that establishes they lack capacity. So when and how is it established? When do we need to query this very strong presumption in law? And I want, in looking at that, really, to refer you to just two. There's lots of them, but these are 2 situations that where the presumption of capacity has been misused, in the sense that it's been relied on in the face of evidence to the contrary, really. So the first one, you can read the full report, the Safeguarding Adult Review there by following that link. So Tom was a young man who sustained a significant brain injury. Even after that initial injury, he had more head injuries to follow, all of which were associated with being intoxicated. He became quite a local character. He had his Mohican haircut and camouflage gear and loud music. He attached a horn to his electric wheelchair to warn pedestrians of his approach. Professionals considered Tom to be intelligent, politically aware, and anti-establishment. After his brain injury, Tom believed that his life was not worth living. He developed epilepsy, chronic insomnia, depression, and muscle and skeletal pain. I just need to move that little thing that's sitting where I can't read it Tom's mental capacity was assumed. So notwithstanding the fact that there were limited references to capacity, there were discussions during various other neuropsychological and neurological assessments. There's a small note of the county solicitor who discussed capacity, but there was no outcome of that. And I'm quoting here from the document itself. Over time, it would have been prudent for assessments to have been carried out in the light of Tom's brain injury and the acknowledgement that Tom was making decisions and it was felt that he could not suitably process information or understand the consequences because of his acquired brain injury. He had difficulty in complying with expectations and he was unable to identify his own risks. The family, who were trying to alert professionals to the fact that they did not feel he was making capacitous decisions, are quoted as saying that they felt they could not make a dent in the professionals' misunderstanding concerning Tom's mental capacity. Tom was situationally incapacitated by exploitative and drug-using peers, a fact that was known to many professionals who did not question the absence of mental capacity assessments. And Tom sadly took his own life, aged 43. So I do recommend actually reading the whole report, but it is just one of many examples where professionals seem to have almost hid behind the assumption of capacity by treating Tom as someone who could make his own decisions, actually in the face of lots of evidence that was being given to them by the family to say there's a reason, a good reason to question this. Another more recent, well, it's not more recent incident, but there's been a lot of publicity around this recently, and I think I have mentioned it in some of the newsletters. So this, again, was a young man, Christopher Lascaris, who was murdered in his home at the age of 24. He was a very vulnerable young man with autism and a long documented history of exploitation and abuse in the community. It's interesting that there's no safeguarding adult review of this because he was not seen to be within the remit of adult safeguarding. If you haven't read more about it, Karen, it's definitely worth reading. So his mother details that he did not receive the support he needed and he lived a reclusive life. His murderer was a drug dealer who had recently been released from prison on licence. He gained access to Christopher's flat when Christopher was left without a secure front door for 5 days after the police broke his door down due to welfare concerns, but then didn't have any part to play in replacing that front door. His mental capacity was not assessed for key decisions, and his mother, Mrs. Lascaris, feels that the MCA should be amended to allow parents or family to request a mental capacity assessment to prevent professionals simply relying on the presumption of capacity. So you will, if you Google Fiona Lascaris, you'll see there's a lot of activity and some sorts of promise about amending the MCA, rather than that first principle just to say, unless it's proved otherwise, that there's some sort of obligation to carry out an assessment where there's clearly reason to doubt it. So again, it's worth reading. So it fits within this sort of sense that we're trying to be, in some ways, empowering, and yet we're doing that through this presumption of capacity, almost in the face of lots and lots of evidence to the contrary. But on the other side of that coin, and I don't in any way want to make less of what's happened to these and plenty of other examples of people in similar situations. Sometimes we can say that somebody has executive dysfunction and therefore they lack capacity. It's seen as something that cannot be improved or supported, and that isn't the case. There are strategies of support that can be put into place that help people who have executive dysfunction. And we don't equally want to see ourselves with such a risk-averse situation that we're ruling people out of any chance of making decisions in their own life. So sometimes people with executive dysfunction do have mental capacity. And some people who don't have any executive dysfunction don't have capacity. I'm sorry, I hope you can follow those two things. What I'm saying is it doesn't all stand or fall on executive dysfunction, because there are strategies we can use, and we need to consider these when we're thinking about practicable steps to support a person to make a decision. Just very practical, simple things when we're talking about this, and we're talking about triangulation. Very simple example from a Dole's assessment. I asked Mr. Smith if he was able to have a wash by himself, and he said that he could, indicating the sink in the corner of his room. I asked if he had a routine, and he said that every morning and night he had a wash. He explained that at home he had a wash basin upstairs. I asked if he could get upstairs, and he said yes, pointing out that he uses the stairs at the care home. Sounds great. But then speaking to care staff, the assessor writes, I understand that Mr. Smith uses the lift at the care home, and he was not able to get upstairs when he lived at home. So the importance of that triangulation, the importance of the issues that other people might raise to you that cause you to question capacity. Okay, so moving on. With mental capacity assessments, it's not something that we only do once. We don't assess somebody once and say, that's it, you lack capacity for that decision, game over. People can learn, develop, and change, and short-term decisions can be made in the short term and then revisited. We don't need to say, oh, that's it, you know, and that's it forever. There are lots of things we can do to support people where we found them lacking capacity, programs of support, which when we then test again, find that they've gained capacity. The other issue that you raised and that sometimes happens is that capacity fluctuates. And these are just a brief few slides on what is a big issue, really. Sometimes that is that the person cannot decide at the moment, but we know that they're likely to be able to in the near future. So that might be a person with a temporary delirium, where we know that actually this is going to settle and they will be able to make decisions in the future. Another type of scenario is perhaps with some mental health conditions, where the person has long periods where they're perfectly able to make decisions, and there are occasional triggers of mental incapacity. Thirdly, we have situations where the impact of the person's condition affects their decision-making on a more variable basis. So this might be what we sometimes call a sundowning in dementia, where maybe earlier on and throughout the day, the person can make decisions without any issues, but later in the day, their decision-making is impaired. So there are different things that we can do to support the person depending on almost which of these three scenarios we're referring to. There's also a distinction between having a fluctuating mental state and fluctuating mental capacity. So they may have kind of ups and downs that come with their mental impairment, but that doesn't necessarily of itself mean that their decision-making is fluctuating. So they may be sort of more impaired than at other times, and that may kind of increase or lessen. There may be triggers. but actually their decision making may remain okay. When we're talking about fluctuating mental capacity, often that means that we can't predict it. At any one time, we may get different responses and different outcomes when we're carrying out an assessment of capacity. The other thing that's important to point out, and dare I say, sometimes professionals disagree. I might find the person to have capacity for this decision. A colleague who is equally skilled in assessing capacity, I've forgotten what I just said now. I might find they have capacity. The colleague might find they don't have capacity. That doesn't necessarily mean their capacity is fluctuating. It means two professionals have come to two different decisions, and we might have a different way of solving that, or of even investigating that. So what do we do when capacity is fluctuating? Sometimes where it fluctuates, and this is really quite unpredictable, we might need to take what's called a longitudinal approach. So rather than doing the one assessment of capacity and finding them to either have it or lack it, depending on how they are at that particular moment in time, we might need to take a look over a longer period of time. So we might need to look at their decision ability over what we might call good times and bad times, and look at overall, when we take that period over a longer time, what period of that time are they able to make decisions and what periods are they not? So is it kind of 80% of that time we found them able to make the decision, 20% of the time we didn't? Sorry. And there's some examples there that you can look at. Sorry. This is not what we want on a recording, a frog in the throat. Sometimes this can be due to acute anxiety, substance misuse, or those more kind of life-threatening conditions. And you will find case examples there that look at all of those that we won't go into now, but you can look at after the session. So sometimes the longer period of time, and it is a valid, I know people will say afterwards, what about making a decision at the time it needs to be made? Well, sometimes we've just got to sort of lengthen the time over which we're looking at it, because we're not getting a fair assessment of the person's mental capacity if we just take that snapshot view. But when you're writing up the outcome of that assessment, you will reference that you have taken this view as a longitudinal view. And in the same way, sometimes there's a sort of separation between big overarching decisions and maybe the little decisions that go within that. So we might say, and this case is one that looked at managing diabetes, there's like a big question: can this person manage their own diabetic condition? Or we could take micro decisions. Can they test can they take insulin? Can they test blood glucose? Can they follow a diabetic diet? Sometimes we have to decide kind of which approach we're going to take. And in this case, if I remember it rightly, the judge was looking at this kind of, if the care staff had to test each one of these small decisions, then the person's condition would not be managed. So the judge approached it by looking at the macro decision in managing diabetes and concluded that the person, although they may have capacity at different times around some of these smaller decisions, overall, taking a macro view, they couldn't manage their diabetes. So obviously, as a direct worker with that person, you would then be saying, well, you know, they were perfectly fine today. They didn't need any support with insulin. They did that themselves. You wouldn't overrule their ability or their decision making when they demonstrated that ability. But looking at this as a big overarching decision to which you could come back to and that would enable you to intervene in their best interests, you would have made that big overarching decision. And really, this is quite a useful way of looking at a lot of the decisions that we make. So there are different types of decisions. There are those isolated one-off decisions, like making an LPA or a will or buying something. We're pretty much looking at the person's capacity to make that decision at the time it needs to be made. Then there are maybe these more repeated decisions that are continual or continuous, like managing a long-term health condition, or dealing with their property and affairs, dealing with their finances, in other words, ongoing, or making decisions around their personal care needs. These are not things that are just done once. These are things that are done every day. So for these continual decisions, we can look more at that longitudinal material time. We can also look at macro decisions. We can look at how the person presents, how that apparent loss of capacity arises. You know, if we know it's at certain times of day or in response to certain triggers, then we're going to try not to have any decision making during those times. We can look at whether these are planned or controlled situations or completely unpredictable, and the frequency of them. Also, the seriousness and the breadth of the impact on their incapacity, on the arrangements. You know, these are kind of serious, life-changing arrangements that you can't really be managed by a person having capacity now, but not having it, and then having it and not having it. We may need to take a more macro or longitudinal approach. But we can do some things with fluctuating capacity that can help us in practice. We can gather the person's views when they're best able to express them. So having these important conversations during what we might have called good periods, or when we know that the person is really at their best. And then we might be able to, or we can then use the information they've given us if we need to make decisions in their best interests. We've got a wealth of information that we have gathered directly from the person about things that are important to them. We can also try and use those good times to plan ahead. What would you want to happen if? So if you entered a crisis situation when you were not functioning at your best mentally and not able to make decisions, what would you want to happen there? How would you want us to support you? You could say to someone who insists on leaving a care home, you know, right now in this discussion, you understand why you're living here and the care and support that you need. What would you like staff to do if you sometimes didn't understand that and you tried to leave? How would you want us to respond to that? So you can try and plan in practice by having some of these conversations at a good time. I've seen people try and use this approach with perhaps alcohol misuse. So talking to the person when they're not using alcohol and saying, if I come later and see that you are drinking, what do you want me to do? Do you want me to get rid of the alcohol? And I mean, I'm not saying it's easy to do in practice because they may say yes, but when you find them later in a different frame of mind, then that's not necessarily something they'll be compliant with you carrying out. Just a couple of others that have been quite interesting, really. I think I've referenced this one before, but it was when the courts looked at belief. In a capacity assessment, does somebody need to believe what you're telling them in order to understand, retain, and use and weigh it? And in this case, the court found that this young woman, initially, the court found that she lacked capacity to make medical decisions because she simply did not believe the medical information she was being given about her prognosis and the impossibility of travelling overseas. This was a young woman with a very rare condition, but she had survived COVID. She was pretty much living on life support. And what she actually said was that she just wanted to die trying to live. So she wanted to go abroad to try this new treatment. She didn't believe the doctors when they gave her a prognosis and the inability to travel, really. The Court of Appeal disagreed and reminded us that this is a two-stage test, that there's no question in there about belief. It's about understand, retain, use and weigh, and communicate. All that is required is that this test is applied. So if your belief stops you understanding the information, then you can record that the person did not understand the information, but you can't record that they didn't believe it, because that's not part of the functional test. Although interestingly, I haven't read this case in full, but this is a more recent case about amputation of this woman's fingers and toes due to gangrene against her wishes, where the lack of capacity here is said to be because she did not believe the medical information. So it's interesting, but this is a court protection decision. The previous one is a Court of Appeal decision. I don't know how we rationalise the fact we've got two different ones. I would personally stick with the approach that was taken in the previous case, and I would not record in any decision that this was because the person did not believe what you told them. I would record if their lack of belief stopped them understanding or using and weighing what they were told. There's a similar issue around insight, where people often put into a capacity assessment, they had no insight into their condition. And again, the court is reminding us that insight is not part of the test. You may not have insight into your mental impairment, but you may still understand, use and weigh, and be able to retain, use and weigh, fancy forgetting the word retain. You may well be able to understand, retain, use and weigh, and communicate. And this was a difference of approach, really, where the more psychiatric clinicians relied heavily on insight, whereas the social worker relied much more on a functional assessment with good evidence in each of these four areas around understand, retain, use, weigh, and communicate. And the judge found that the structure of that capacity assessment was an excellent example of providing relevant detail at each stage with clear reasoning to underpin their conclusions. So all roads really are leading us still to this functional test. And therefore, it's that functional test that we need to be good at evidencing. And a judge has said, capacity assessments which most protect rights are criteria focused. So they know what the issue and decision is, and they're focused on that. They're evidence-based. So there's good evidence in each of those four areas: understand, retain, use and weigh, and communicate. They're person-centered. So there's something about the heart of the person in this, and they're not judgmental. So they're not seeking to put what I think should be the right thing. They're looking at an assessment with evidence, and they're sticking to those areas of the functional test. I've given you just one link at the end of this session on fluctuating capacity, because it will take you to a webinar on that, which was delivered by the Essex Autonomy Project. And that is the last slide. And thank you for listening.
So on behalf of Partners in Care, thank you for joining this mental capacity webinar, and thank you very much, Lorraine, for delivering that content. I think it's given us a lot to think about in terms of the challenges of assessing capacity. I think it was really detailed. So thank you, Lorraine.